Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I'm with Max. How are you doing today?
I'm doing great. Thank you for having me, Dennis. I really appreciate it. It's always a pleasure to be here and talk to you and help out in any way I can.
Awesome. Well, the pleasure is definitely mine. And today, not because of a traumatic experience you've had, I actually want to know some stuff that you know on this one. So, modern combat has definitely changed, and with that kind of change, then you're going to get a change in wound patterns. And one that I am particularly scared of is the top-down kind of penetrating trauma. So I would really like to talk about neck injuries, upper chest injuries, and how to manage this, definitely pre-hospital at least. So if you wouldn't mind, just for my basic understanding, my 6 weeks of anatomy training, I believe everything that keeps you alive runs through this small corridor between your shoulder and your head.
Yeah, it's the upper extremity and upper extremity junctional injuries specifically are one of two things that as a trauma surgeon keeps me awake at night, that bring me true pause. The other thing is a right upper quadrant abdominal gunshot wound, just because there are so many things in that area that a high velocity gunshot wound in the right upper quadrant can take out probably at least 6 or 7 major organ systems, all of which are different to treat and problematic. And the lower neck and upper chest junctional injury is the same, with the added caveat of it being extremely difficult to get control. Because unlike the groin, where you have a junctional injury where it goes from the leg into the abdomen and there's a whole bunch of soft stuff on top of a whole bunch of hard stuff, and I don't want to say it's easy to get control, it's easier, right? Enough pressure over the groin and you can get at least temporary good control of a bad junctional injury in the groin. Not always. We've all kind of been in either of those lanes or real world scenarios where we've seen groin junctional injuries be extremely difficult and frustrating. But still, I would challenge you that even a moderate upper extremity junctional injury is orders of magnitude more difficult to control than a lower extremity junctional injury, just based on the anatomy and the importance, right, of like what you said, what else is in the playing field, right? And so the way that going over some anatomy, right, basics of anatomy, the way that we break up the neck and the shoulders, right? So let's talk about the neck first, and then we'll get into the clavicular area, right? We have zones of our neck. That's how we determine as surgeons what we're going to need to do to get, one, control, and two, our surgical approach. But it's important for you to understand, because this is the time when you should be at least setting yourself up in like, okay, the mindset of a surgeon, right? What should I pre-hospital be concerned about? So zone 1, it starts from low to high, right? So if you're looking at me, zone 1 is basically sternal notch to cricoid cartilage, and that's zone 1. And obviously in that region is all the stuff that I'm very concerned about. That is common carotid artery, a nominate vein, low trachea, potentially phrenic nerve, esophagus. And what makes that area so concerning is that as a surgeon, if I see something in that area, I'm immediately thinking that there is not just neck involvement, but chest involvement. And so already I know that I need to get ready to do a sternotomy or a thoracotomy, or at least a clavicular head resection, right? And those are all big surgical maneuvers that require training and experience and quick decision making, and you don't have a lot of leeway. Bleeding out from something that's only this far off of the arch of your aorta is extremely fast. And unlike the groin, where you can get direct pressure or open the abdomen and clamp an iliac, getting proximal control in the chest is not a quick thing. You also have to be thinking about chest tubes and stuff, and we'll talk about how to treat all that later. But anatomically, zone 1, sternal notch to cricoid cartilage, that's going to be zone 1. That's all that high value arch of the aorta stuff. And again, everything in the neck. Zone 2 is going to be cricoid cartilage to angle of the jaw. And from a surgical standpoint, that's probably, if I had to have a neck injury, the place you want to have it, right? Because it's all at that point in time tubes that are easily exposed, right? And so in the neck, we talk about the trail of safety. And so again, just bringing a surgical point into what I'm thinking when I see it, so that you guys can have a better understanding pre-hospital, is that everything is based on the angle of, or the medial aspect of the sternocleidomastoid muscle. So if you look right here, this is the medial aspect of the sternocleidomastoid muscle. And what we do for surgeries in this region, the zone 2, you make an incision right here along the anterior border, and then you pull the sternocleidomastoid lateral. And you're always making incisions medial and pulling things lateral. Even when you're doing tracheotomies or crikes, the medial aspect of the neck is actually the safest. When you start venturing out lateral, that's where all the bad stuff is, right? Medial is safer. The only thing you're going to hit medial is the airway, usually what you're trying to hit. And then behind that, the esophagus, which you don't want to hit. But if I had to have an injury to anything in the neck, it would be one of those two, as opposed to the other important stuff out here, right? So anterior border of the sternocleidomastoid, bring that lateral, and now you're looking at the jugular vein. And there's one branch that goes across of the jugular vein, the facial vein, and you can clamp that, and then bring the jugular vein lateral, clamp that and tie it off, or clamp it and dissect or transect it, and because otherwise it'll tear and you'll get some bleeding. You pull that jugular vein lateral. Now you're looking at the carotid artery, the common carotid, and where it branches to external and internal, all in that zone 2 area. You pull that lateral, now you're looking at your vagus nerve. You pull that lateral, and now you're going to be looking at, either if you're on the patient's left side, the left neck, my left, it's a little backwards, but if you're on the left side of the neck, you may be seeing the esophagus. You pull that, you actually keep that medial, and you pull everything else lateral, and now you're looking at the vertebral body, and potentially some bleeding from the vertebral arteries. And so again, the landmark you should know and understand anatomically in the neck is the anterior border of the sternocleidomastoid, and know that at that border, going straight down kind of laterally, is all the important stuff. So if you are medial within the borders of the anterior sternocleidomastoid muscles, you're safe, right? As long as the trajectory was head on. The trajectory, the entrance wound and exit wound, entrance wound is here, exit wound is out lateral. Now you need to start being concerned about all the things I just talked about, right? So that's zone 2. Zone 3 is another area of great concern, because it's the angle of the jaw to the base of the skull. And that's where the internal carotid enters the base of the skull. It's where the external carotid goes into all of its 12 freaking branches and just spreads out everywhere. And again, each of those little arteries, while it may not have a deficit when it's ligated, a significant deficit, because there's so much collateralization, they can be sources of major bleeding. And getting control of the angle of the jaw, you can feel on yourself, there's not a lot of space to get packing or put pressure, right? You got this big bone in the way. You have the big sternocleidomastoid kind of in the way. And between the two, if you were to separate them, there's this posterior belly of the digastric muscle that crosses the whole thing. And so getting to the vessels surgically is very challenging here. And then also it all dives into the base of the skull. And guess what? If you have an injury at the carotid artery at the base of the skull, you can get control of the lower part, but getting control in the skull, because that's going to back bleed a lot, that's a problem. That's a big, big problem, right? Now let's talk about the chest, or the upper extremity, right? If we're looking, I'm gonna strip for you guys a little bit, but it's good demonstration. I apologize. So if you're looking at me, this is kind of what we call the deltopectoral groove. If someone's laying down flat, there's usually like this little kind of sorry. If someone's laying down flat, right? There's kind of this little angle you can see where your pec and your armpit and shoulder meet. That's called the deltopectoral groove. Or if you have someone out, there's usually like a little kind of groove here. That's the deltopectoral groove. The way that the what we call the subclavian and axillary blood vessels is if you follow your clavicle comes out straight for about 2/3, and then it angles up really hard. That angle straight to the deltopectoral groove is where your major blood vessels run. So that angle where your clavicle goes from straight to angled up, that angle straight to the deltopectoral groove, down below the pectoralis major and the pectoralis minor, it's pretty deep. It's about anywhere from 4 to 6 centimeters deep, is going to be your axillary artery. Underneath the subclavian proximal, it's called underneath your clavicle proximal, it's called the subclavian artery. And then as it exits underneath the clavicle, it's called the axillary artery. And it goes to this groove right here and then dives down and becomes your brachial artery. So if you have someone like this groove, as it goes to your middle arm, comes up and then goes straight across like this. And it's all right here is all the important stuff. And on a lot of our operator dudes, those are big guys. That's a lot of muscle to get through, right? And unfortunately, for upper extremity junctional injuries, you have this big bone in the way, this clavicle bone, right? And the clavicle bone is very problematic because it does make getting pressure on that area harder, but it's not impossible. We'll talk about that in a sec. You also have important stuff underneath. Your stopgap, unlike the groin, which is the pelvic brim, your stopgap up here is your chest. So you have clavicle, lots of important blood vessels and nerves, ribs, lung, right? And your chest cavity. We'll talk about that, why that's important, because your chest cavity, even though you're not bleeding outside anymore, you can still now be bleeding into your chest because the apex of the lung, if you're looking straight at me, comes up above the clavicle. There is still thoracic cavity up above your clavicle. So now you have, if you're going more central, you have clavicle, important blood vessels, lung, and then other stuff. Now when you're talking about above the clavicle, you've got other stuff too, like your phrenic nerve, right? And so packing up above the clavicle, you do what you got to do, but you just be careful because now you're talking about packing into the chest itself, into the lung, right? Or packing to the point where you're tearing the phrenic nerve. If you're up here in this central region above the clavicle, right here, you're going to have where your common carotid comes up and branches off into your subclavian. The common carotid comes up and the subclavian comes up and then dives back down. And this whole region, kind of this like fancy L or chair, right here, that area can be really bad because now you're talking about an injury that's at the junction of the left subclavian and common carotid. And it's not a great place to be. And oftentimes you are going in the chest. So I would venture even to say that because on the right side, usually in most people, when we're looking at the arch of the aorta, the subclavian comes off separately. And then it's its own branch off of the arch of the aorta, or not always. It's actually, I apologize. On the right side, it's usually they come off together and then they branch. But surgically, it's easier to get control of the right side because those are the first vessels to come off the aorta. If you're looking at the aorta, it comes up, curves to the left and down. And that means that even though the carotid and subclavian on the right come off as a common branch usually, and that is a higher risk of up here where you can hit both at the same time, Surgically, if I do a median sternotomy or a thoracotomy, they're right there in front and slightly easier to get control. I would not say that anything in what we're talking about surgically is easy, but it's right there in front. Whereas the left side, as that aorta dives back, those branches come off further back. And getting control, if anyone listening is a surgeon, you all know how difficult it is to get control of a left subclavian artery in the chest. I mean, you are reaching really far back in there, especially if you're doing what I do in emergencies, which is a clamshell. You are really trying to get up high in the chest to clam something, and even then, it never makes you feel great about your proximal control. The median sternotomy is really the exposure for proximal junctional injuries of the base of the neck. It is the gold standard. I mean, it gives you access to everything right there. However, a sternotomy takes a lot longer and a lot more special instruments to do and to get access than a clamshell, which can be done with a knife and scissors. So that's a trade-off from a surgical standpoint. How's that on the anatomy review?
No, that's great.
Good.
That's great.
Yeah. I apologize. One more thing to think about the neck is that that we talked about the rate of bleeding, right? And keep in mind that neck injuries I classify as a junctional injury, right? Because it's just so close to where it's coming off the aorta. It's neck injuries, upper extremity junctional injuries, traditional chest, upper extremity chest injuries, anything around the clavicle. Your distance to the aorta is centimeters or inches at most, right? In the groin, your distance off of the aorta is much longer because you're going through the iliacs all the way down as they get to the leg, right? We all know that if you have a open femoral artery injury and you let it bleed out, it's going to be 4 minutes until you exsanguinate, roughly. If you get external control and the bleeding is now bleeding into the thigh is a great capacitor for blood. It can take a lot of blood, about 1 to 2 liters of blood in a big thigh, right? In the neck, you don't have that. There is not a lot of space in a neck to accept a lot of volume. And you're either going to bleed out at a rate that is a lot higher and faster than 4 minutes, right? Or if you are not bleeding externally, the neck can't absorb 1 liter of blood before other things start getting pushed on. And this is a key concept from physiology to understand, because I see it even with doctors that they don't understand, is that when you have a hematoma in the neck, you lose your airway, not because the hematoma is directly pushing on your airway. Your airway is a big tube with cartilaginous rings, and it's very stiff. Imagine trying to choke someone. We used to have this in El Paso, very, I'll just say interesting attending, who used to get very emotional and yell, and he'd be like, he did a lot of thyroid surgeries, and he would always be like, choke yourself. We'd be like, what are you talking about? He'd be like, choke yourself. You know how hard it is to choke yourself? That takes a lot of force and a lot of energy. And we were like, where are you going with this? What he was trying to say in a really weird way was that it takes a lot of external force to collapse a trachea. And you're never going to get that much force from a hematoma to directly collapse your trachea. What happens is the hematoma builds up in the neck, and all of the little capillaries in your trachea all of a sudden see too much pressure. It only takes 25 millimeters of mercury to stop blood flow through a capillary bed, which is why when we intubate someone, if you look at guys in the hospital, they have those little pressure monitors for the balloon. That number is 25. If the balloon is exerting more than 25 millimeters of mercury of pressure from the inside, you are putting ischemia on the inside of the trachea and potentially causing damage over time. It's the same thing from the outside. if that hematoma builds up, what happens is you don't get direct pressure on the airway. You get swelling of the airway, almost like an anaphylaxis. The airway swells because it gets venous congestion and capillary congestion because the hematoma from even an arterial bleed is pushing on the trachea, and the trachea is not able to drain its venous blood, and the trachea swells. And that is an important thing to understand when you see a patient who has a hematoma in his neck and he's able to talk and phonate and isn't hoarse yet, just know that that's a ticking time bomb. Because what's happening is a guy's got a big hematoma, right? And you're like, oh, well, he's phonating well and he's protecting his airway. But you need to be thinking like, oh, shit, his trachea is not draining venous blood. And it's only a matter of time before, as this gets bigger or even stays the same size, the trachea is swelling. It is a very, sometimes slow, sometimes fast anaphylaxis. So think of like when you have a hematoma here, he's having I would say, traumatic anaphylaxis of his airway. And that's important to understand from a physiologic standpoint.
Would you start hearing stridor? Late, probably?
Yes. Now, that being said, know that when you have a big hematoma and you start hearing stridor or hoarseness or difficulty phonating or difficulty swallowing, you are almost behind the curve at that point. I would say you are behind the curve because not only are you starting to get swelling of your trachea, but your anatomy is going to be off, right? And you have a bleeding problem. You don't just have an anaphylaxis problem. You have an anaphylaxis problem on top of a neck bleeding problem, on top of a unique anatomical problem. Like the stuff in the neck is not going to be where you think it is. It's going to be getting pushed, right? The airway itself is going to be swollen. When you go to intubate, you're going to have a lot harder of a time, especially if it's up higher. The pharynx is going to be pushed into your line of sight. The trachea is going to be off. It's going to be swollen. There might be blood coming out of the mouth. So if you're waiting for what I would say those hard signs to show up, you're making it way more difficult for yourself. So point number one is in the now progressing into treatment is that you all have heard, maybe some of you have heard my previous podcast with you and my opinions on the matter of less is more when it comes to airway. I'm a firm believer that in hemorrhagic trauma, we are intubating people way too fast, and especially in a mass cow scenario. If someone does not have neck trauma, that's the big caveat, does not have neck or airway direct trauma, and they're protecting their airway, then you let them do their thing. However, if they have evidence of direct trauma to the neck, swelling, hard signs, then you got to take that airway fast because it is only a matter of time. You go do something else and you come back and now that guy's really hoarse. Well, getting an airway in that setting is going to be a disaster, right? And it may be too late. Yeah. Let's talk about hard signs real quick. So when I'm assessing someone for neck trauma, I'm looking for hard signs. I'm looking for obviously external bleeding and expanding hematoma that is expanding in front of my eyes. An audible bruit. So if you have a stethoscope or you put your ear to their neck, you can hear like a rumbling sound. That's telling you that the blood flow is disrupted. Either there's a dissection in that blood vessel or it is flowing not just in the tube but also out of the tube. There's turbulence, usually evidence of bleeding. A palpable bruit, so you might not even be able to hear it, but you can feel it. You can feel like a rumbling, or any of the stuff we talked about. So hoarseness, difficulty phonating, difficulty swallowing, all that stuff. And then bleeding out the mouth too, right? So those are all things that if I look at that patient and I see any of that stuff, I'm like, we got to get access while we're getting the airway. Like those are happening right now. Probably in that specific situation, Airway for if I had to choose between one, and I'm getting the Airway first. So.
Because you can suck up as much time as you need trying to get hemorrhage control first.
Oh yeah. I mean, you got to protect that airway because that airway is about to get lost. And then that's it, right? If you don't have this going on, then you do your HemCon, get blood in, do all that other stuff. But if this is swelling and they've got those hard signs, you got to jump to protect the airway. That's in my opinion. Yeah, absolutely. Yeah, because the longer you wait, you're losing a window, and it's going to be a nightmare. And if anyone
that
out
makes
there,
absolute sense.
yeah, if anyone out there has tried to do a surgical airway on a neck trauma patient with a big hematoma, oh man, it is a nightmare. It is a nightmare. Yeah.
And it's definitely you learn to appreciate suction.
Oh,
because once you open that up, if it communicates, your incision somehow communicates with that hematoma, it's not going to be easy to see.
No. And now you have an airway and you're trying to pack around the airway, and it's a whole problem. If you can get in a tube in the mouth in that setting, and then deal with the bleeding separately, it's a lot better. It's a lot better for you and the patient. Yeah, for sure.
I think anatomy-wise, refreshed. So let's start talking about like zone 1. Let's just jump to the scary one.
Yeah.
Because I got to be honest, I don't know that there's much I can do for zone 2 or really zone 3. Definitely not zone 3. I don't think I can really do much of anything. So just from anatomy-wise, my guess is tourniquets don't work. So, like, how would I understood? Hey, we probably need to take that airway early, but just like the hemorrhage control, I've heard like a million different techniques, and I've seen many of them fail.
Yep.
So I guess how do I use my anatomy knowledge to make a more effective hemorrhage control?
Yeah. So I'm gonna pause real quick and say, you said there's not much you can do for zone 2 and zone 3. I would say there actually is, but it's going to buy you an extra person. So when I see a neck trauma patient come into the trauma bay, I know that I need someone, or even pre-hospital, that's a 3-man battle plan, right? It's the patient, they're out of the fight. It's you, the medic, taking care of them, you're out of the fight. And it's a third person who's going to be this, and they're out of the fight. And the reason it's not you or the patient is because usually the patient's out. We're going to talk about a very interesting video that we should reference and link to later, where the patient, if they're able to, can actually be the third man, but don't count on that. But it's a 3-man battle drill. Just in your mind, think that for neck, both zone 2, zone 3, and zone 1, which we're going to get into exactly what you're talking about, is a 3-man battle drill. You got the patient, they're out. You got you doing all the stuff that you got to do, which we'll talk about here in a sec. You're out. And let's talk about that third person, is holding pressure. It is not uncommon that with neck and upper extremity junctional injuries, that there is someone who is holding pressure on the wound, adequate pressure on the wound, because again, it's not hard. All this stuff is only a centimeter or 2 under the skin. It's not hard, but it's going to require you to have your finger there until you're in the OR with me. I can count on more than one hand the amount of times I've had a police officer, a medic, a med student, a resident, an ER nurse, an ER medic come to the OR with me and hold their finger in a neck while we are prepping around them and their finger, and putting gowns on them. Like, they're not getting, they get told very quickly, hold your finger here and do not fucking move it. And we will do everything around you. You are the show at that point, right? And I'm thinking of one dude at Fort Huachuca, must be 15 years ago now, who had an injury, and he held pressure for an hour and a half flight to Phoenix, and the guy lived. But I mean, that dude for an hour and a half of his life was this, right? And that's, tourniquets have replaced a lot of that, but not in the neck, right? And so we had a resident one time on a real bad zone 3, zone 2 injury. We had a guy who had a neck infection that eroded into his common carotid, and he came into our trauma bay just bleeding out. EMS had his finger, and then one of our residents put his finger in, and he held his finger there for almost 6 hours while we stabilized him in the trauma bay, got him to the OR, and then vascular surgery went in intravascularly and stented across that injury while he was holding his finger there for 6 hours. And so, what you can do for zone 2 and zone 3 as the medic, and you're coming up on this guy, get someone with you and have them hold pressure, whether it's externally or if there's a hole there, putting their finger in that hole until the hematoma stops getting bigger. And that is all that they are doing until you get them to me. And then I'm going to take that guy from you and keep him with me until I'm ready to move his finger and start cutting. Does that make sense? Yeah. So now let's talk about the really scary one. Zone 3, right? And around the clavicle, right? Same thing. You're still going to need that third man, because they can still hold pressure, even if it's right above the manubrium, right? We have a thing called Utley. We have zone 1. I apologize. Zone 1, the real low one. I apologize. Yeah. Zone 1, you can still have someone get their finger all the way in there pretty deep and feel where the bleeding's coming from and just start holding pressure. We have this thing in surgery called the Utley maneuver, when there's a trachea that erodes into the innominate vein right here. And that maneuver is you put your finger in that trach hole, you curve it down under the sternum, and you pull all those blood vessels up on the underside of the sternum. And guess what? That person's finger is going to stay there until the median sternotomy happens, right? And so there are a lot of ways to get your finger deep in there and hold pressure on what needs pressure, right? And that's the first step. Oftentimes, it can be the best step because we're going to talk about, ways to get control, right? So if it's very central, right? If it's within the borders of the neck, like let's talk about this right here. If it's within the borders of the neck and the hole is within the borders of the neck here, you can't really put external pressure on that. You can't, right? Because you have your two clavicles coming in, you have your sternum, and you're not going to be able to push enough to close that entire thoracic inlet. And you also don't want to, right? Because if the hole is here, you don't want to close the whole thoracic inlet and basically cut off everything to the head, right? One, you can't. Two, you wouldn't want to if you could, right? Because that would be tourniqueting the neck, right? So in the borders of the neck, medial, you can't put pressure externally, right? So now you're talking about you've got to either pack in that hole or you've got to put your finger in that hole, right? And that's what you got to do. Now, let's talk about what to do when the hole is too small to pack, right? Because we've all been there. 5.56 rounds, they're literally these little tiny fucking holes, or shrapnel injuries from a frag, right? That can be a tiny, tiny, tiny hole, right? So there's 3 options that I tell everyone, and they all have risk, okay? One, if you can't get your finger in the hole. If you can get your finger in the hole, it's easy, right? If you can get your finger in the hole, you can get packing in the hole. So we're not talking about that, because if the hole is big enough to where you can get your finger or packing in there, do that. That's the thing to do, right? Like, put the packing in there. If that's not working, the packing comes out and you take your finger in there and you jam it in there, and now that's your life until you're at a surgeon or the guy dies, right? And so that's, I wouldn't say easy, but that's the easier option. The hole that has been created is big enough to receive a finger or packing. Done. Let's talk about now the hole that's too small. Okay, what do? There's 3 options. They all have inherent risk. You can take your finger or hand, put that over the hole, and try to just hold pressure that way. Sometimes it works, sometimes it doesn't. In the groin or in the lateral neck, that often works. You can just put your finger over the hole and hold pressure. Centrally, it doesn't always work. And even though you're holding pressure over the hole on the outside, you can still have a lot of bleeding into the mediastinum, right? That you're not seeing. So what else do? You can put your finger over the hole. That's option 1, and just push as hard as you can. Option 2 is you close the incision. You stitch it up. You throw a couple whip stitches to just close the skin and make that airtight, and then hold pressure over that. And I say that because, like, when I did my trauma training and we did a lot of ECMO, right? The skin is a great barrier. It is an incredibly strong barrier. It's leather, right? It's airtight, it's watertight, and it holds tension extremely well. And so if you have a tiny little hole in the groin, and they're bleeding out from it, or even in the lateral neck, you can whip stitch that real quick and prevent them from externally exsanguinating. It's still an emergency problem, but they're not going to bleed out and bleed to death within minutes or seconds. Now it's still a problem, and you've turned a minutes to seconds problem into a half hour, maybe 1 hour problem, right? Because now they're not bleeding out, they're bleeding in, right? They're bleeding into their chest, they're bleeding into their mediastinum. Still a major surgical emergency, but they're not going to die in the next 5 to 10 minutes, right? However, you're creating a tamponade. You still need external pressure, but it helps you with the external sanguination. However, you need to train that. You need to, 1, have the appropriate equipment. So you need to have a needle driver readily available. You need to have some sort of durable suture, whether it's a silk or a nylon or a Prolene or something. And you need to know how to stitch fast and effectively. So if you don't have those skills, that's not an option. And when you're seeing the bleeding patient right there, that's not the time to learn or we'll figure it out, because you'll be there looking for the appropriate material and trying to do it and doing your two-handed tie or your instrument tie, and they'll be bleeding to death. That is not the time. So the time to put that option in your toolbox is now, and making sure you pack the appropriate equipment for that and train that of like how to do a good watertight, airtight whip stitch fast and effectively. So again, if it's in your toolbox, it is an option. If it's not, then train it now or take it off the table, right? So what's option 3? Option 3, which is pretty controversial. However, if the first 2 options are either not an option or not working, your only other option is to make the incision bigger, right? The skin incision bigger. Again, we talked about how there's a lot of important stuff here. So this is not the time that you're just like carving that guy open like a turkey. You are literally opening just the skin enough to get your finger and packing in there. That's it. You're not doing a big dissection to try to find anatomy and clamp something. No, you are taking a little tiny 2 millimeter hole or 9 millimeter hole, and you are opening it up just enough to get your packing in there to do effective packing, or your finger in there to do effective tamponade and control, right? And And then I would put a chest tube in. Once that's done, the airway's protected. The third thing is to do a chest tube on that side or both sides if you can't tell. Chest tube or finger Thor, whatever. Whatever is in your SOP. 1 for therapeutic and 2 for diagnostic. Because you want to know, like, okay, I just had an injury here in zone 1. I have protected the airway. I've gotten external control to the best of my ability by either putting pressure on over the wound, sewing it closed and putting pressure on, or opening it up and packing. Now I need to know airway's protected, not bleeding externally anymore. I think I have HemCon. Are they bleeding into their chest now? And that is decided and figured out by the chest tubes or finger Thors to identify it and treat it, right? Now let's talk about out lateral. So out lateral, you've got a couple other options, right? Let's again talk about, now we're talking about the lateral injury. We'll talk about the lateral injury above the clavicle, right? So we're talking about an injury that's kind of right here. This is a scary one, right? It's lateral to the neck and it's above the clavicle. So now I would say it's actually, you can try to put direct pressure on the clavicle itself. However, it won't always work, because usually when we talked about anatomy, if you remember, above the clavicle means that it's not traversing under the clavicle. Lateral to the clavicle, the vessels start inside and then they come up and then they come down under the clavicle. So if it's above the clavicle, chances are that it is proximal to the clavicle, meaning that putting pressure down on the clavicle is not going to stop it. So stepping on the clavicle, putting your body weight on the clavicle, trying to do something over here in the armpit, none of that's going to work, because all of that is proximal and above the clavicle. So lateral and above the clavicle, again, I would treat that the same way we talked about medial neck, right? So borders here we just talked about. This is also treated the same way as this right here, this triangle right here. Same thing. The thing is that it's easier to get pressure out here than it is here, down here, right? Because the thoracic inlet right here, you can't close that with pressure. Here, you can put your finger over the hole and hold pressure, right? We've all seen this in like movies and stuff like that. You're holding pressure here. You can actually pinch the trap and get good pressure there externally over that tiny, tiny hole. Again, we're talking about the hole that is too small to pack inside, right? So putting your hand over that, putting your finger over that, and pushing and pinching, that's option 1. That's what I would do. And guess what? The person doing that, again, they're going to be doing that until they get to me, right? Option 2, you can whip stitch that closed and do the same thing. Whip stitch it closed so they're not bleeding outside anymore. Pinch it real hard. Intubate them while this third guy, remember, this third guy's pinching this. He whip stitched it so he's not bleeding out. He's pinching. You're intubating. You're putting in the finger Thor, right? Option 3, make that incision bigger and you pack in that space. Just pack, pack, pack. Pack, put your finger in there, put your hand in there. And now we're going to talk about what I think you're trying to get to, which is the concepts of like how to work around the clavicle, right? I know you've all heard of like tying around the clavicle, like getting a Kelly clamp, making an incision above and below the clavicle, and then putting a umbilical tape or a shoestring or something, and then getting it underneath and tying it. I would not recommend that. I would not recommend that because you have 2 large blood vessels that run under the clavicle, your subclavian artery and your subclavian vein, and it's not like a textbook, especially if there's a big hematoma there. It's not like a textbook. and they're not going to be just right under the clavicle. So you cannot tell me that if you just blindly pass a Kelly clamp under the clavicle, that you're going to get underneath both of those structures safely enough to pass a string around it and then tie it up. There's so much that can go wrong with that. That's something that I do in the operating room, with a lot of light and a lot of careful dissection, right? And there's other things that can go wrong too. Even if you did get lucky enough to go underneath those vessels and not just rip right through them with your Kelly clamp, you're now passing a shoestring or a piece of umbilical tape underneath the whole thing. And guess what? Those shoestrings and umbilical tape, they're going to grab all that tissue and just start ripping, right? And so you can get lucky on shot 1, and then shot 2, when you go to pull it through, you just cheese grate all those important vessels. So it's not something I would recommend. I know you've also heard feeding like a Foley catheter balloon in there and blowing that up. I've either seen it make, I'm not a fan of that maneuver, because I've 90% of the time I've seen it fail, and the other 10% of the time I've seen it make things a lot worse just by just blowing everything up, so it is not something that I would recommend. I've just never seen it work. They put a little Foley in there and they blow up the balloon, and it either pops out, or they blow it up and there's still bleeding around it, or they blow it up and now there's a lot more bleeding around it, right? I wouldn't do that either, right? If you're going to put something in the neck, it needs to either be very directed and effective packing, or it needs to be your finger, right? So again, when we're working around the clavicle, those are the 3 options. Direct pressure with just your hand over the hole, close the hole and direct pressure, and either tamponade, use the skin to tamponade for you, and then make sure it's not draining into the chest, or make that incision big enough for your finger to get in there. Then you can put your finger in there and pull everything up against the underside of the clavicle and hold it there. Or get your finger in there and go down and hold where that bleeding's coming from and just bury it in there and hold pressure that way, right?
Okay.
So now
do you think a chest seal would be enough to close the skin, short of whip stitches?
Yeah, it
or
could
staples?
Staples, yeah. Again, like, people always think that stapling is going to be pretty easy. I would say it's not. It's enough to help out, right? Like, if you don't have that in your toolbox, you can maybe put a couple of staples over it and then a chest seal. I'll tell you that I am a fan of chest seals. I carry them all the time for when I do cut downs or chest tubes or finger Thors or airways or central lines. I use them as my surgical duct tape, pre-hospital. But I have also seen chest tubes just, especially if it's arterial bleeding, what'll happen is that it'll tamponade for a bit, but then all that blood gets in there, and then you get the blood bubble underneath the chest seal, and then you're now 10, 20 minutes into your flight, and all of a sudden blood's just coming out under that chest seal, right? Whereas, give it a shot, but watch it, right? You're going to have to watch that, because it is not the definitive tamponade effect. Nothing is better at tamponading externally than your own skin, right? It's what it was designed to do. Keep everything in. It's leather, right? It's untreated leather, right? And so if you can bring that skin to skin with staples, sure. I haven't had much luck, especially with those old school skin staplers. There are newer ones that have kind of the longer bites, and if you have someone pinch the skin up, you can get a good bite with staples, yeah. But knowing how to just do a good, tight, effective whip stitch, that will really recreate that tamponade better than a chest seal, better than anything else. And so now let's talk about, did that answer the question?
It sure does. And then you're just talking pressure wise. You're just talking anterior, posterior pressure, or am I directing that pressure in any direction?
if it's above the clavicle, again, and this is something I always tell the medics when I'm training them for junctional injuries, it's not so much when you have your finger buried finger depth in a wound, right, in the junctional area, anterior posterior pressure is not the best, right? You want to be guiding that packing and then your finger where the vessel is coming from. If you're holding external pressure, right, like the hole is too small to pack, then yeah, you're just pushing down on that space and trying to collapse that space anterior posterior. If you're now packing in a wound, you're now below the level of the skin, packing in the wound and putting your finger in there. It's not anterior posterior. It's in the direction of where the vessels are coming from, right? So again, in the neck, everything's coming from central. So if I have an injury above the clavicle out here, I am putting my finger in towards where the big blood vessels are coming from. I am packing towards where the big blood vessels are coming from. I'm tamponading from where they are coming from proximal, right? Same thing with the groin, right? If I have an injury in the groin, I'm packing up towards the inguinal ligament and the abdomen because that's where the problem's coming from, right? And so now injuries distal to the clavicle, right? The junctional injury in the neck above the distal to the clavicle. So now we're in a slightly better option and position because now we can use the clavicle to help us. There's this thought that you can't put pressure anterior posterior on a upper extremity junctional injury. I would say that that's crap. You absolutely can. And what I would say is that for all the people listening out there and training medics, do this exercise. Get an average sized guy and then get a big guy and a small guy and have the small guy and the big guy both get up above that guy and put their entire knee worth of weight or step on their clavicles. It's not, you're going to have to get some volunteers. And you might break a clavicle. Don't do that, but like start slow and low, don't like just have a guy jump on your buddy's clavicle, but like have them put their knee and their body weight or even their hands and their whole body weight like they're doing CPR, right? And push on that clavicle and then check their pulse distal in that limb or with a Doppler, right? You would be surprised. Even someone a little less than average size, if they put their whole body weight on that clavicle, can sometimes be enough to get the clavicle to pinch those blood vessels against the chest wall. And that's your answer, right? If you can do that, then do that, right? Again, we're talking about where the hole is not big enough to pack, right? If the hole's big enough to pack and it's bleeding, you all know what to do. Pack it, put your finger in it. That's the problem solved, right? At least until they get to me, right? We're talking about the hole that's not big enough to pack. You get that guy and you push on that clavicle, and guess what? If the clavicle breaks, that's style points lost, but it makes it easier to get control, right? Because now the broken clavicle, as long as those broken edges of bone aren't lacerating the blood vessel, but like now you're pushing down on those blood vessels and you're getting control. And then the other things that we talked about are still effective, right? Like putting your finger on the hole and holding pressure that way. We kind of just talked about that with the clavicle. 2, whip stitching it and holding pressure. And 3, making it bigger and packing, right? And so that's what I have to say. Yeah.
Yeah. Awesome. I mean, I think it's wise to have at least some guiding principles that will work for any kind of injury. It's just a matter of, okay, what angles am I doing? Like if you can get your finger in there and you can feel that pulse, or you can feel the bruit, or however you want to describe it, put direct pressure on it. And then now you have your stopgap complete, hopefully, at least on the proximal side of it. Between that and the heart, you have some kind of control. And then you can sort out, okay, how am I going to get my packing and stuff like that? And mimic that pressure to complete the task.
Yeah.
Now we're talking about where the blood is coming from, obviously. Pack that. Some of these major arteries, you get one side, now you have back bleeding coming from the other side. Is that something I also need to control, or is that minimal?
If we're talking about, I mean, at that point in time, it's if you're packing right, like it you don't necessarily need to worry about that. I mean, it's not like you're going to put a tourniquet on the arm distal to that injury, because, I mean, you can try it. I don't think it would be necessary, especially if you have just one hole and you've packed effectively, because even if there is complete transection of that vessel, right, the packing, the spread of them is not going to be to the point where you're going to have to pack here and then pack here, right? They're not going to go that far from each other. If you get enough adequate packing in there, one, the venous pressure head is only 7 to 11 millimeters of mercury. That's not a lot. I mean, that's like this much pressure. And so I wouldn't worry about that too much. You will get that with your packing. The distal end of the blood vessel and the back bleeding, again, the neck and the upper extremity areas are so tightly compact that if you're packing into that space adequately enough to get effective control proximally, you're also packing into that same very small space to get effective control distally, which is a lower pressure head. Does that make sense? So as long as you're packing to get hemorrhage control, you're good to go. Yeah.
And then once you get that kind of hemorrhage control, then you roll. I'm assuming somebody is getting access and starting blood while all this is happening.
Yep.
So wink, wink, train your teammates how to get access.
Yep.
And then you're rolling into doing some kind of decompression, whether that be a finger Thor or just straight into a chest tube. And
yes.
Would you say, because I would imagine if you're getting it done that quick, that the guy is still alive, it might not be enough blood going into the chest to actually cause a hemothorax or some kind of outward signs that I need to decompress this as well.
It might not be. And that's what I said is like, it could be, right? Especially if it's these more proximal injuries. I mean, the rate of bleeding out here can be the same as the rate of bleeding down there, right? And so it could be. So if you have the ability to put a tube in, I would, because finger Thors are great for decompressing, but they don't really tell me exactly how much they're bleeding in the chest. And it's a lot harder to control that bleeding. You can just slap a chest seal, but like I like the chest tubes in those situations because I can re-expand the lung. I can see exactly how much bleeding is coming out, and if it's too much bleeding, I can clamp the chest tube, right? Like if I put the tube in and all of a sudden I fill a atrium, or it's clearly more than a liter of blood that just came out, I'm clamping that chest tube, right? And I'm now giving that guy all the blood I got or can afford to give him, and getting to the surgeon and saying, I had to clamp the chest tube. There's that much blood coming out of the chest. And now I know, okay, this is a chest and neck problem, right? Or a neck problem that's bleeding into the chest, right? And so yeah, just to recap and going over the orders of work, like you said, training your other medics and the people around you. You know, I'm a huge advocate of that, right? But again, that is more just stressing this point that this is a 3-man battle drill. When you as a medic see someone with an injury in this AO, your first thing should be to grab someone with you. Like that's step one. Find someone, bring them with you, and they are the one getting pressure. So make sure they fucking know how to get pressure. Make sure they know how to pack under your guidance or pack without your guidance. Make sure they know how to hold effective pressure. Take them to the LTT lanes or take them to the other lanes. Like whatever training you did to get effective pressure, Make sure that they are going through that too. It's not hard and will, in this case, save a life. 100%. So step one, find a partner. It's a 3-man battle drill. Patient, you, and the finger, right? Grab the finger, have the finger do what fingers do, right? Your job now is an airway. Protect that airway. Then your job is, probably depending on how the patient is doing, access and blood or finger Thor. But that's the next step, right? And then once you've got your finger doing finger stuff, your airway secure, access, and a chest tube, now you can start doing stuff like giving blood and all that. But like that would be my battle drill, right? And so again, like the finger is not going to be the one doing the suturing, is not going to be the one doing the opening the incision more and packing it. That's going to be you as the medic who's trained to that stuff, right? So again, see a guy, just to hammer it home, you see a guy, get your third person 3-man battle drill. The finger goes and does finger stuff. Even if the hole is too small, you just have them put their hand over it and hold pressure as best as they can, right? Or if the hole is big enough, you have them pack and put a finger in there. You get the airway. Then you can maybe take a tactical pause, see if this is effective or not. If it is and the guy's doing okay, go to the chest tube. If it is and the guy's not doing okay, access and blood, and then chest tube. And then reassess, okay, is he getting effective pressure? Okay, he's not and the hole's too small. Okay, what am I going to do? Am I just going to whip stitch it, or am I going to make it bigger to get my finger in there? And that is pre-hospital what my orders of work would be.
What would make your decision to close it or open it? The size of the hematoma and the rate of bleeding, right? Like if it's not a big hematoma and it's not bleeding too rapidly, but I'm just not able to get effective external pressure and or I need that guy to go do something else now, then I would whip stitch it closed and put pressure on it myself or transition him to holding pressure, right? Like if you have someone who's not medically trained at all, like literally just a fucking civilian bystander, right? And they're holding pressure and they're just not doing it good and there's still blood coming all around their hands, but it's not a big hematoma and it's not a really, really fast rate of bleeding, but it's just not, what you're doing is not effective, then that would be where I would like, okay, well, let me just whip stitch this so that at least they're not bleeding externally. And now I can just take this civilian's hand or untrained hand and just put it on there and hold pressure. If they're trying to hold pressure and it is a big hematoma and it is just exsanguinating around the hand and it's just not working, then I would probably move to just making that hole slightly bigger so I could just get some packing in there, right? Also, if you don't have, this is something we didn't talk about, but sometimes there's blunt trauma to the neck, right? And there is a big hematoma from blunt trauma or a tiny little penetrating injury and a big hematoma, and you can't get the airway, right? Like then you need to make that incision bigger to decompress, right? So if it's now, let's say the hole is out here, right? And there's a big hematoma out here and you can't get the airway. You go in endotracheal and it's just blocked off and there's blood in the mouth. And then, okay, do I cut here to evacuate the hematoma and then try to cut here? I wouldn't do that. But what I would do is I would cut here, evacuate some of the hematoma, and then get to the airway that way, right? And so yeah, sometimes being able in the neck to evacuate the hematoma to protect your airway
is an option as well. But again, we're going all the way back to step one, right? Which is like, it would be actually step three, right? Get your battle buddy, step one. Step two, have your battle buddy be the finger. Step three, you're getting the airway. Okay, well, let's say you're going for the airway and you can't get it because this hematoma is so fucking massive, right? Then go to your surgical airway, scoop out as much of that hematoma as possible, get your airway, and now you can either reach in to get packing around the airway. I've seen that too, right? I mean, you remember the story Dave Harden with someone we know very well, holding pressure on someone's neck. If you ever talk to him about that story, he had a big incision over here that was that had swollen up and was compromising his airway. Well, if you talk to Dave about that very frantic drive, it's actually interesting because Dave was holding pressure on this guy as he was coming to me, and I was the one in the operating room that took care of him and stopped the bleeding. And it's like talking to Dave, while he was in the car and at his house, was having to simultaneously hold pressure, but then intermittently release because he was awake. The patient was awake and having to protect his airway. And Dave would be holding pressure to stop the bleeding. But then after a couple minutes of doing that, the patient was verbalizing that he was having trouble breathing. So Dave would then have to accept a little bit of a couple seconds of bleeding to allow for decompression of the clot to allow him to breathe and then start over again. So it was this game. If you talk to Dave, it was extremely frustrating because he was like, I'm holding pressure, but now I'm going to lose an airway and I don't have anything for an airway, right? And so I would have to release some pressure to let the hematoma out so he could breathe, and then I'd have to hold pressure again. And it was this battle of just doing this, right? And so that's something to keep in mind too, why airway is so important to get so quickly so you don't have to be doing that decompression pressure. Because if you don't have an airway, you might actually have to make that incision a little bit bigger or make an incision midline to decompress to get your airway and then get pressure, right? It's a battle. Yeah. So bottom line, don't get to that point. Get the airway early, right?
Awesome. Well, we're already pushing an hour.
I know.
We just talked about zone.
we should talk real quick about the Kentucky Ballistics video. Yeah. So there's
sure.
a video. You'll put the link out, I assume, or you'll show some of the video. I want to say, but like there's I think Scott from Kentucky Ballistics. There's a video a couple of months ago. He was shooting a high caliber, a 50 cal rifle, and it exploded in his face. And he obviously suffered blast injury. The end cap of the rifle came off and hit him in the orbit, and he had blunt trauma to the face. And then he also took a piece of the insides of the weapon, came through, and actually buried right above his sternum in a zone 1 junctional injury. And his father was with him. I think him and his father are both prior law enforcement, so they had some basic combat life-saving skills. And his father basically took his hand, the patient's hand, and his finger and put it in the hole. In the hole as far as he could go. And when you hear the Scott talking about this, he put his entire finger in his neck above his sternum and was able to hold it there. And you even see in the video, he puts his finger in and then he takes his other hand and pushes it in even further to get pressure on the hole because he said before he did that, there was just so much blood coming out. And he was able to hold pressure with his entire finger in his chest and his other hand adding pressure to it long enough to get him to the hospital where the surgeons basically transitioned his finger with packing and then got him to the OR and did a median sternotomy to get control he says in the video it was his jugular vein, but the way that he was describing it, it was probably a carotid artery. Regardless, listening to his story about what two people can do with a very bad blast and penetrating injury fast and effectively. I mean, like, you want to talk about these guys. I don't know if they were lucky or just incredibly smart, but like they did all the right things in a very timely manner and saved his life. And it's a great story. He's a great storyteller. And I think it hits a lot on the stuff we talked about today. Yeah.
Yeah, no, he walks through the whole thing. I tend to think that they got like super lucky.
Yeah.
But they definitely didn't. They did all the right things. And number one, getting immediately to the hospital.
Yeah. Yep. 100%. Yeah. And you can tell, just the stuff he was doing to keep his mind right and oriented, and the first thing they did when they got to the hospital is they took his airway, right? They changed his finger packing out to actual packing, but then immediately got an airway, right? And so it's a great story, a real, I would say, vignette that touches on a lot of the stuff we talked about today. From an open source, non-military vignette, but still related to firearms. So pretty much like military adjacent. Yeah. So, yeah.
Awesome. Hey, I really appreciate you jumping on, Mac.
No, thank you for having me. As always, I love being here. Your channel is just an amazing resource, and I'm just so happy to be part of it and help in any way I can. Thank you for having me.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast, out.